talk to you a bit today about my work, primarily work that I've done with the Adolescent Trials Network, which many of you are aware of. It's an NICHD, NIDA, and NIMH-funded research network focusing on developing interventions for HIV-infected youth in the United States. I know with this audience, I do not need to go deep into details around epidemiology around HIV among youth in the US, but I will just set up maybe a bit provocative argument about how we think about what's happening in the US with our epidemic. And then I do want to talk to you about some research I've done over the past 4 or 5 years with the ATN, and then really get into one protocol that really focused on substance use, mood, and other psychosocial factors using a daily diary method that I employ in a lot of my research today. And then I'll just conclude with some final thoughts. So I wanted to start with, again, it's a little to provoke you a bit around this idea that I think we've all seen now, the idea of ending AIDS. It's a big feature of public health, not just at the local level, but the national level. We have a 2015 blueprint here in the New York State Department of Health. The city is also on board with this notion. And so one of the things I've really contended with, both as a scholar and someone who does research in this area, but also someone who's interested in how we present public health problems, is this idea of ending AIDS. Is it realistic or is it just a slogan? And it is something that we see taken up on many different parts of the country. We see different terminologies used. So San Francisco Department of Health has their mission of getting to zero. We all know of the PEPFAR plan from the State Department and hopefully soon to be President Clinton's remarks around an AIDS-free generation. Again, this idea that we can end AIDS, have a generation that doesn't have the experiences that we've had and that our friends and families have had. And it's also in the popular discourse. The New York Times earlier this year talked about the world could end AIDS if it tried, and the UN goal of ending the spread of AIDS by 2030, which is only 14 years from now, and that we all know is not really that long a period of time. So if we think about realistically ending AIDS, we have to think about young people and really thwarting the number of new infections among young people. That is the true way to end AIDS. We know in the United States, youth are disproportionately affected by HIV, particularly sexual minority, and more specifically MSM, and also racial and ethnic minority youth. 40% of infections in 2014 were among individuals between the ages of 13 and 29 years old. And again, I don't need to go over this graphic with you. We all know that of those younger people, they tend to be Black and Hispanic MSM, including also white MSM, and then African American females. So are we really ending AIDS? We know that we have a really powerful biomedical toolkit. We have the ability to understand this cascade or continuum, or however we want to call it. We increase HIV testing. We have more people diagnosed. We link them, get them into care. We have them take up treatment and stay in care, and eventually they reach viral suppression. And if they maintain viral suppression, the likelihood of them transmitting HIV to uninfected partners is very low, and we all know this. This is in some ways the paradigm that we all refer to, we all go back to. This is the new way that we end HIV/AIDS in the US. But it's not really working at all if you take a look at the actual data. So if you, this is taken from MWR, but also some work that Ken Mayer did with colleagues, to look at and try to create the cascade for youth in the United States. And so we have about 80,000 youth in the United States that are HIV infected. Only 40% though diagnosed. So we already have a huge chunk of folks that don't even make it into the continuum, if you will. They're not even diagnosed. When you look at linked to care, only 25% of that 80,000 youth. Retained in care, 11, and this to me is just unacceptable. And it also, I think, runs very much counter to this idea of ending AIDS when you have a 6% viral suppression rate among the young people who are, again, the future of not just our country, but our age-free generation. So, in my sense, this is like the day that is going to never give me any let up. Sorry about that. In my opinion, right now, ending AIDS is a slogan. It's a powerful slogan. It is a call to action in many ways, but it is still a slogan. And it's more about political rhetoric, I think, than actually what we need to do with our epidemic right now, which is focus not just on biomedical and technological strategies that will help us facilitate getting to viral suppression, but also addressing, and I really want to emphasize, these behavioral and structural approaches. We know that NIH, CDC, governments around the world are really putting a lot of effort, a lot of resources into PrEP, into treatment as prevention, and into getting folks into that continuum and getting them suppressed. And that's really important, but that can't come at the expense of investing in behavioral and structural approaches. And that's really the point that I'd like to make today, and hopefully show you some data that supports that statement. So as I mentioned, I really want to tell you about work that I've done with the Adolescent Trials Network. NIH funds this network. Again, NICHD, NIDA, and NIMH are the primary funders. And I really want to focus on a protocol that I worked on when I first started with the ATN, really two protocols, ATN 086 and 106. And what we did, it's a pretty straightforward, simple protocol. We were really interested in assessing the youth of the Adolescent Trials Network on psychosocial and behavioral factors, connecting some of those factors to medical data. But it really had never been done. We have a great number of youth in the network, but we didn't really have a profile of what they all look like in terms of, again, in behavioral and psychosocial variables. And so the ATN actually has, over the course of the time that we did this work, 20 sites, 15 sites initially, 5 sites that were added when the ATN was renewed for the third iteration. We had about 1,700 participants in ATN 086, and then an additional 500 or so from ATN 106. So we had over 2,200 HIV-infected youth ultimately that we could look at, which is one of the largest, if not the largest, sample of HIV-infected youth in the United States. These are some of the sites you can see for the original ATN. These are the first 15 sites. Many are clustered here in the Northeast, but they represent parts of the South, West, and Midwest. And then with new sites added, we also got a few more locations in the West and South, and also Puerto Rico. So the main goal of this project, as I said, was to just present and obtain essentially demographic and psychosocial information on the youth in the network. We were interested in looking at demographics, sexual risk behavior, substance use, mental health. We also had medical data on their viral load, CD4 count, length of time since diagnosis, and also whether or not they were had art, were prescribed art, and also were engaged in care. We also, and I won't present on it now, but we had some really great, with the help of folks here at Columbia actually, we added geocoded data to the data set so that we could really start looking at neighborhood predictors. And again, while I don't have time to present it, we did find some very interesting observations when it came to neighborhood level effects on things like adherence. So one of the first analyses we did after we finished data collection, and this was really from the ATN 086, with the sample of 1,712 young people. And this was actually, I have to say, this was my idea to look at our sample this way. I liked these clustering types of analyses, and I think it's a very interesting way to provide a description of a sample or a group. And so what we did is basically decide to create profiles based on 9 different risk variables. And I realize this is a somewhat complicated diagram, but it helped us get a better understanding of the types of groups, if you will, that exist within our youth. And so we came up with 5 classes. This is a latent class analysis that we did, looking at how youth cluster on these 9 variables. So we're looking at alcohol use. This was daily or weekly alcohol use. Pregnancy, past pregnancy. We looked at previous incarceration, problem drug use using the CRAFT, which many of you know of and is used with this population. We looked at daily and weekly tobacco use, daily, weekly marijuana use, having only one partner, having 2 or more partners, reports of unprotected sex, and then reports of sex while on drugs. And what we came up with, again, were these 5 classes. This first one we call low overall risk, and it became our reference group. Now, while this group did have, these are probabilities here, conditional probabilities that you would report this behavior. So they did have risk behavior, but pretty much overall they were pretty low on all of our 9 risk behaviors, risk variables, if you will. Our second class we called high-risk substance use. And you can see these guys were defined primarily by their substance use behavior. They had a 90% chance of having problem drug use if they were in this category. They also had higher rates of tobacco and marijuana use. Here, this is high-risk sexual behavior. This was a group that was defined primarily by having multiple partners and having relatively high level of unprotected sex for this group. Our fourth group, high-risk sexual behavior and substance use. Again, these folks were highlighted or identified through their problem substance use, but also through their sexual risk behavior. And then we had a final group which was really representative of young women who had past pregnancy, and that's why we call this group past pregnancy risk. So these were the young women who had been pregnant at some point, and I will say many of them were perinatally infected. So what we did is really just try to describe, so how do these profiles differ? And as I mentioned, we used our low overall risk class as our reference group. And what we saw is that youth in the higher risk classes were more likely to be 18 or older, they were more likely to be male, they were more likely to be unemployed. We saw that specifically for the high risk sexual behavior class. They were more likely to be behaviorally infected. They were more likely to be gay or bisexual or other non-heterosexually identified, diagnosed in the past year, particularly for the high-risk substance use, high-risk sexual behavior, and high-risk sexual behavior and substance use groups, have considered suicide in the past year, again, mostly for the substance use classes, high-risk substance use and high-risk sex and substance use, and then have reported mental health problems based on the BSI. So what this tells us is that, first, that not all youth look the same. I mean, that was really one of our key points, but that we may even need to think about targeted and tailored interventions based on behavioral profiles, and that we do see that for some youth, substance use might be the main driver of potential issues or problems. Others may actually combine substance use and sexual risk behavior, but there's not just one sort of look when it comes to this population. So we wanted to delve further into explaining, in this case, condomless anal intercourse. And I realize that some might say, well, that's an antiquated or outdated outcome to look at if we're talking about HIV, given that we live in the day and age of treatment as prevention and PrEP. And I really want to counter against that, and I hope, again, in the next, not this paper, but the next paper I present, you will see that we still need to very much be focused on sexual risk behavior, that it's a very important conduit for perpetrating the epidemic, if you will. So we looked at predictors of condomless anal intercourse. This was an article I wrote with Jake Vandenberg, who's at Brown. And he was very much interested in looking at different variables and how they were intertwined and related to condomless anal and vaginal sex. And this is, again, with our full sample from including both HIV-infected young men and women. And we was primarily looking at substance use, including frequency and severity, emotional distress using the BSI, and social support. And really want to see how these factors worked independently to impact condomless anal and vaginal sex. But we also wanted to look at how these effects could be mediated by self-efficacy for risk reduction and alternative risk reduction attitudes and behaviors. And this was really a construct Jeff Parsons and other colleagues put together, a measure that really focused on ideas of either youth having ideas of, well, if I'm virally suppressed, I don't need to use condoms, or if I have HIV positive partners, I don't need to use condoms, et cetera. And what I really want to highlight, I know there's a lot going on here, as there always are in these structural equation models, but what I really want to drive home are some of the direct effects that we see. The only variables that we saw direct effects were frequency of substance use, severity of substance use, and emotional distress. For the other effects for social support, it's fully mediated by those variables of self-efficacy and alternative risk reduction strategies. Partial mediation for the substance use and distress variables, but there's still something happening here, and I highlight these variables because they come up a lot in my work. Substance use and mental health issues. You saw a little bit of it in the previous description. You're seeing it again here. Again, it's the same sample, so I'm not trying to say that this is something brand new here, but we now have a little bit extra information to see how this plays out. And so that takes me to work that I focused on, again, with the same team, same sample, but now focused specifically on young men who have sex with men. And so we have our full sample. We were really interested only in MSM, so we took out youth who were born female, and then we took out any young men who had not reported sex with a male partner in the past 3 months. So we were using the definition of MSM here. These men were identified as gay, bisexual, heterosexual, and we did have some transgender women in this sample as well. But we had 991 of our initial 2,225 that were HIV-infected, born male, and reporting one or more male sex partners. And then of those, and this was obviously very disconcerting, 688 who had a detectable viral load. And we really were interested in looking at the behaviors of those young MSM with a detectable viral load.
Can I ask a quick question? Patrick, when you did this, did that virtually get rid of a large chunk of your perinatal infected, or?
Yes. All of the
Did you hear that? No. I'm
Sorry.
just saying basically this gets rid of most of his perinatally infected.
Almost all these young men were behaviorally infected, yeah. So almost all the, and I have another piece I can share with you where we really looked at the perinatally versus behaviorally infected and differences on a lot of these variables, and there were some stark ones, as you can imagine. So what we first wanted to do is look at just basic differences among virally suppressed and virally detectable young MSM. And so you can see again, our full sample was 991. And we wanted to look at just basic demographic factors. We wanted to look at incarceration and housing, substance use, and mental health. And you can see that there are, again, some stark differences between those who are virally suppressed versus those who are not virally suppressed or virologically detectable. Those who are detectable were more likely to be older than 21 or 21 or older. They were less likely to be employed. They were less likely to have a post-high school education level. We also, I mean, as you would imagine, those who were prescribed ART were more likely to be in the virologically detectable or undetectable group. And then we saw, well, and I should also point out incarceration. Those who were detectable were more likely to be incarcerated. And then we have a cluster of findings around mental health where we looked at depression, anxiety, and then the overall psychological distress using the BSI Global Severity Index score. And we saw significant differences across the two groups. Perhaps the most sad but also important finding were the differences in condom-less anal intercourse and serodiscordant condom-less anal intercourse, and there were significant differences. I mean, we first see overall about a third of our sample had serodiscordant condom-less anal intercourse, but they were more likely to be the virologically detectable as opposed to the virologically suppressed. So virologically detectable youth were more likely to engage in transmission risk behaviors than virologically suppressed youth. So I mean, this again is one of, I think, perhaps my top evidence that I want to share with you today to highlight the need for still focusing on sexual risk reduction, in addition to increasing behaviors that will promote adherence, that will promote engagement in care, and obviously get youth to viral suppression. So looking at just the virologically detectable young men, the 688 detectable young men, we wanted to then see, okay, well, what are some of these predictors of condomless anal intercourse? So we first did univariate analyses looking at just each variable in relation to the outcome, condomless anal intercourse, and then serodiscordant condomless anal intercourse. And then we did multivariate models based on those that emerged as significant in the univariate model. So I do want to highlight that each of the variables you see here were significant in univariate models, though only the first 5 here emerged as significant in the multivariate model. So we looked at transgender. Again, we had a few number, but we did want to pull that out. And transgender individuals were less likely to report condomless anal intercourse, as were those who reported black race. This to me speaks a great deal to the social network influence of how the transmission works in these particular communities. Those who disclosed to sex partners were less likely to report condomless anal intercourse. And then we see, again, our substance use variables, those with a CRAF score of 2 or greater, which indicates problematic substance use, more likely to report risk. Those with daily alcohol use also more likely to report risk. We didn't see our mental health variables emerge as significant in the multivariate, but again, they were significant in a univariate context. These findings now speak to serodiscordant condomless anal intercourse, and here again, each of these variables came out or emerged as significant in the univariate models, but in the multivariate, the first 3 maintain significance, including being currently employed. Those who were employed were less likely to report serodiscordant CAI. Again, those who reported being black were less likely to report serodiscordant UAI or CAI. And then those with a CRAF score reporting or that indicated problematic substance use were more likely. So this again highlights, and while my mental health variables did not emerge again as significant, I still had this feeling of these factors are just incredibly important in explaining risk. Certainly the mental health variables in explaining adherence and engagement in care, or at least viral suppression, I should say. And so that led me to really want to do more work looking at substance use and mental health. But just what do these findings tell us? Well, as I mentioned, treatment as prevention alone will not be an adequate strategy because not even 2/3 or not even 1/3 of our youth in the sample were virally suppressed. And I might add to you, which I think is even more remarkable about this finding, these are youth who could be considered linked to care in some way. Now, we struggled in the ATN as to how I was going to describe this because some youth really are, and I mean, I know those of you who belong to networks or HPTN, when we talk about being connected to care, there are many different definitions. Some of these youth may not have been at the clinic for several months, but they did come in to do an assessment and to get their medical charts abstracted. So these are youth who are connected in some way to a clinic and that go to that clinic. So just imagine the youth who are not connected to care, what would we see if we really had a true probability sample of HIV-infected youth in the United States? It would probably be way, way worse. So we need interventions to help address substance use, to help address mental health, employment, education, and incarcerations. And I really, again, have considered the roles of mental health and substance use as very important here. Alex?
Patrick, maybe I missed it, but do you have any measure of adherence to medication?
We do. It's self-reported. We were looking primarily at just viral suppression here. I don't think we asked. We did ask, but I did not look at this in the MSM subsample. We didn't look at self-reported adherence at that for this particular paper.
Because you're building your argument on they are not virally suppressed, but the most likely reason is that they're not taking the medication for whatever reason.
Right.
Lack of access, So it seems that there's a big piece of information that is needed to explain this, right?
Well, yes, I guess it could be a poor assumption, but that is the assumption I'm making, is that they're not adhering to their medication. But I guess I'll also add a good chunk of these youth are not, half of them almost aren't even prescribed ART. And again, these are youth in care. So one of my conclusions I was going to come to is that we have to also think about with youth, and particularly those that are more in the 13, 14, 15, and I'm imagining Claude has heard this, but in my just conversations with these young people, they are not even ready to be on medication, and that is why they actually aren't. Their doctors don't put them on it. In spite of the CDC regulations or recommendations, I should say, kids talk a lot about the idea of being, it being a reminder of their HIV. They're afraid of their side effects. And many doctors that are in our network, I won't name names, but don't put the kids on meds because they know they won't adhere to it. And so they wait for them to be adhered. And I think we have to come to terms as HIV clinicians and researchers that not all kids will take meds, and they may not be ready to take meds. And how do we work with that? But I see, and I take your point, and in my next presentation of this, I will talk more about adherence. So let me just quickly get to this connection between substance use, mental health, and risk. When I was last here, I reported on some findings from daily diaries that I did, or this was a weekly diary where we looked at connections between depression, well-being, and risk behavior in a sample of substance-using HIV-infected MSM. And we saw these findings where we looked at when people were more depressed than usual, they were more likely to engage in risk. When they were happier than usual, they were less likely to engage in risk. And this just, again, made me think about these connections between substance use, because it's a substance-using population, mental health, and risk. And so we did another ATN protocol. This one focused specifically on using daily diaries to examine substance use and mood, which are the two factors I'm going to focus on, but we also, of course, looked at adherence or medication adherence, sexual risk behavior, and substance use. So this is the ATN 112 protocol. Here we were looking at acceptability and feasibility, as well as initial outcomes from a daily diary study. I'm not going to talk a lot about the acceptability, feasibility findings. Those have been published in AIDS and Behavior, and I will just say that we found this method of data collection to be very much feasible, with some caveats, given that this was administered in a clinic setting. But we really were focused on looking at over 66 days, the interrelationships among mood, stressful events, social support, substance use, sexual risk behavior, and adherence to ART. This was a small sample, but with intensive data collection. So we had 67 young MSM from 3 different sites: Children's Hospital of Philadelphia, Wayne State University, and then University of Colorado, Denver. Our eligibility criteria included having had sex with a male in the past year, having had substance use in the past 3 months, and we needed folks to have, of course, internet and phone access, because these diaries were conducted over the phone. We used 2 different types of modalities. Again, I'm not going to get into that because that's more the acceptability, feasibility work. But essentially, we screened them. They were randomized to first. This was not an RCT. We just wanted to start kids differently on the different modalities. So they're randomized either to start with a cell phone, IVR, interactive voice response type diary, or IWR, meaning interactive web response diary, where they would use their phone to click responses. They did a baseline assessment. They got trained on how to do the modality. They did that second modality, or that first modality. They did the second modality, and so on. And again, while we did find that this is feasible, I understand we imposed a structure upon this that would not necessarily be realistic for every study. Our demographics, these are primarily racial ethnic minority young men. Mean age was 21, and they were pretty much all behaviorally infected through same-sex sexual behavior. Just to quickly show some of our compliance, we did quite well. Not as well as the last diary study I just did with Claude, but we did nonetheless really well for this sample. The The two different lines are modalities. The youth clearly preferred the internet, the non-voice response option where they could just type in onto their phone. But we had about a 70%, when you look across the modalities, about a 70% compliance rate, which is really good for these types of studies. So thinking about why we do this approach, why do we do a daily diary, it's really so we can answer between person and within person questions. So a between person question we might ask is, are young MSM who use drugs more likely to engage in condylomous anal intercourse than people who do not use drugs? So this is really about person differences. But what we really are focused on and we're interested in looking at are within person differences. So is a young MSM more likely to engage in condylomous anal intercourse on days that he uses drugs versus on days that he does not use drugs? And this really helps us understand that things like substance use are not static. We change, they vary over time. Some of us have a glass of wine every day when we come home from work. Some of us might have many, many glasses of wine on Saturdays, but then nothing during the week. But yet, when you ask me how many drinks did I have in the past week, I'll say 7, you'll say 7, but that gives me really no understanding of how you behave or how you actually engage in wine drinking, if you will.
Just take that randomly.
I just think about myself, honestly. I'm probably both. I'm like, every day a little bit, and then on the weekend, sorry. So here you get person-level observations. We had 67 young men started, but 61 complete cases who actually went through the full diary. And then we also have day level. We have almost 2,600 completed diaries. So you can look at both observations at the person and the day level, and that's sort of what we did here. So we used the profile of mood states, which is a very easy to administer, quick, but reliable and valid measure of mood states. And we looked at 5: happiness, calm, anxiety, depression, and fatigue. And these findings actually they're just essentially our means and standard deviations here, but they do tell a lot in terms of what the sample looks like. So these variables are in the range of 1 to 5. And you can see overall, this is looking at the day level, but you can also see the person level, meaning this is just looking across days, not people at all. This is more people averages. But on average, youth were happy in their days, and overall reported, relatively higher levels of happiness, calm. Anxiety, depression, and fatigue. Well, anxiety and depression, I should say, were on the lower end of the range, and then fatigue a bit in the middle there. But this is the kind of cool stuff you can start to look at when you assess people daily in terms of their mood. And so one of the things that we were just descriptively interested in, well, how do these mood changes by day of week? But we really saw that there was a stability, again, across days. It's not looking at people so much, but across days. The mean, that black line that is hardly visible, but essentially shows us what the average was. What we liked here, though, is that all of our categories are being endorsed. You see that for happiness, youth just tended to be in that sort of mid-range. For anxiety, which is what we want to see, a little bit lower, though we did have certainly folks who were reporting more at the upper ends of the spectrum. We also looked at substance use, and among our youth, it just really is the case that alcohol, nicotine, and marijuana are the most frequently used substances. We look at other legal drugs, including amphetamines, opioids, ecstasy, other stimulants, but they're just used, or they're reported to be used quite seldom in our sample. And so we highlight and focus on really alcohol, nicotine, and marijuana, since those are the most often used. And again, you can see we can look at days used out of our 66, but also you can just look at what might be more interesting in this moment, the number and percent reporting use, and then the number of days that they may have used it. So we had 90% reporting alcohol use, a little over half reporting nicotine, and about 2/3 reporting marijuana use. We did have almost a third reporting illegal drugs, but it was just so sporadic, and again, it wasn't something that we could look at easily with the diary. And then I'm not actually going to focus that much for the next few slides on sexual risk behavior, but of course I did want to present what we found. And I should add that these are ongoing analyses. We just have submitted one paper, but we'll have, I hope, at least 3 more from this data set that will actually delve deeper into sexual behavior generally, and then of course looking at risk. But not unlike what we saw in the 18-086-106, there's pretty high levels of risk. We had expected all of our guys to be sexually active. Not all of them did report sex in the 66 days, but 84% did. About 2/3 reported any unprotected anal or vaginal intercourse. More than half reported serodiscordant. And then we broke it down by receptive versus insertive, and over 1/3 reported having insertive UAVI with HIV negative or unknown partner, so serodiscordant or high-risk transmission behavior. And of course, we'll be looking at those encounters very closely as we delve deeper into this data. So we also looked at things like stress. And here we just looked at the number of days reported. We asked youth about things like financial problems, transportation problems. And you can see financial problems were most often reported, then transportation problems. So we're talking about sort of structural issues: money, transportation, work. They talk about conflicts, feeling sick about 10% of the days. But the vast majority of stressors seem to be closer to the finances, transportation, and again, some of the more structural issues. But you can see that there were still a diverse assortment of stressors that were endorsed by the youth over the 66 days. We also looked at daily support. And here we were looking at support received and given. And youth primarily talk about receiving and giving support from their partners and friends. This may be due more to the age. This was a slightly older sample. I said the mean age was about 21, so we don't see as much from parents. But again, this helps to get a picture of, in some ways, the sources of support and the places where support is given for this sample. So here's where, again, I want to make this point that we can't look at things like substance use, we can't look at things like mental health, and we can't even look at things like sexual behavior in such a static way. So this is looking at variation in our 3 primarily used substances: alcohol, tobacco, and marijuana. And what we did is essentially look at patterns of use and basically break them up into what it would be considered low in our sample, average, and high variation. So you can see this is for alcohol. This is a person who's, for our sample, and this again, we looked at sort of like the first third, the middle third, and the upper third. So this represents someone who's probably, maybe having a drink or drinking like every week, once a week or so. Here you have more of a perhaps like every 3 days pattern, and this is much more of a perhaps every other day or on and off. Here's another, though, example of low variation. There's tobacco use, and you can imagine that this would be a pattern that we would see of a smoker, someone who smokes every day, and then there's a day that they didn't. But they pretty much are smoking every day. So low variation, there's not a lot of movement there. Versus another, again, a youth who's more, every other or every few days with some breaks versus more of a on-off. And the same with marijuana use. Here you have someone who's just uses, it seems like once, every 2 months, since we track them about 2 months, more weekly, and then, as you would imagine, we have daily use and people who are more on and off. But we also looked at affect, and this is, again, really important to me in my work. I've really tried to make a point that when we look at constructs even like depression and anxiety, not so much clinical depressions where we're looking for a cutoff, but when we're just looking at an average level of depression or anxiety, that only tells us something in that moment. It does not tell us about that person, really. And we have to be cautious of how we interpret the findings from our cross-sectional surveys when we see that someone has a depression level of X. Because they may have a depression level of X plus 20 in a day or two. And that's what sort of these graphs show us. So again, we see high or low, average, and high variation. Here we have our happiness domain. And I want to emphasize, though, even with our low variation, you still see fluctuations. So this is on a scale of 1 to 5. This person is pretty happy, generally speaking, over our 66 days. But they dip to almost a 3, but are a high of 5 over those days. Here we have more variation. This person is not as happy. They've had some days where they were much more at the lower end, but then they had some days where they seem to be modest. And this person is really going up and down. They have extremely happy days, and they seem to have extremely sad days. Same for calm. You can see this pattern of going up and down, but this person is relatively on the lower end of the spectrum. Another pattern where you can see, and who knows what happened in these particular times, but where someone experienced greater sense of calm, but otherwise no. And then, again, a lot more squiggly lines here indicating variation. We also looked at anxious and depressed. Here's a person that is not very anxious, but you see some spikes, someone who probably, perhaps that was a panic attack, who knows? But someone who is not very anxious typically, but had a spike. And then you have someone who's going more in depth. Oh, tell me about it. This is me on the L train. But compress it for 60 minutes as opposed to 60 days. But yes, you're getting the point. We experience these fluctuations, again, based on circumstances, based on situations. And the great thing about the diary is we can start to capture that and then look at how those circumstances or situations impact and play out when it comes to things like mood and substance use. So here, again, this is stuff we just submitted, and we're still actively working on this data. We focused primarily on looking at the relationship between mood and substance use because that's where we had the meatiest data, to be honest. Predicting sexual risk behavior episodes when you have daily measures of nicotine, say, or alcohol use, but I only have, out of every, say, 7 or 8 days, one episode of sexual behavior, it becomes a little challenging. So we have to look at our sexual behavior data a little differently than we have here. But basically what we did is now look at how substance use predicts 4 types of affect. And the reason that we did it as substance use as a predictor of affect is when we asked questions on the diary, we asked youth, did you use alcohol today? And they would say yes or no, and how much. But then we asked them, how do you feel right now? The best way to assess mood and feeling or affect is actually to ask people how they feel at the moment as opposed to tell me about the whole day, because what research has shown is typically they talk about where they are now. Even if you say, how are you feeling? How did you feel today? Well, I'm feeling a little anxious because I just had this experience, and I'm probably going to say I feel a little anxious, even though when I woke up this morning I was not. So we looked at how substance use, which preceded the feeling, essentially affects feelings. And what we see, and this is a nice thing, you can break down into our between level effect, so typical levels of use versus within person effects, daily fluctuations in use. And what we see here, and the pink represents trend level significance, the yellow at 0.05 or less. But those who used alcohol more on average experienced more happiness, greater feelings of calm, and greater anxiety, which could be considered ironic, but that also sort of makes sense if you consider what perhaps the effects of alcohol may be. Yes, I'll be done in 5 minutes, definitely. We also looked at daily fluctuations in use, and we see, though, on days in which youth used alcohol, they were more likely to say that they were happy. On days that they used alcohol, they were also more likely to report they were calm. And interestingly, which is different from our between-person effect, on days that they used alcohol, they were less likely, the negative coefficient tells us, to report feeling anxious. Nicotine, our main finding here was that those who use nicotine were more likely, or were less likely to feel anxious. Again, this might be the stress-reducing effects of nicotine for some people, whereas we saw that those who, on days that they used nicotine, were more likely to feel depressed. Again, sort of running in some ways, not counter, but you can almost see that substance use may be a way of handling or working with different moods. And then finally, when we looked at marijuana use, and this is something that I know for the ATN we've struggled with, what do we say about marijuana use, particularly in a country that is rapidly moving to legalize marijuana use? We actually have seen therapeutic effects of it among youth, particularly when it comes to dealing with stressors. And here we do see that on days that when youth use marijuana, they were more likely to report being happy. I guess who wouldn't, right? Right. It gives us validity to our findings, I guess. So what does all this mean? First, I think that there are deep interconnections between substance use and mental health, and we know these are also two driving factors that come when it comes to viral suppression and adherence, as well as sexual risk behavior. So more work is sort of needed to unpack how this stuff works, but I think that we have clear support for the idea of the interplay between these three factors. And so I just want to go back essentially to where I started. So we know, and I don't say anything negative about our toolkit. I think the prevention toolkit and the treatment toolkit is better than it's ever been before, and we should be incredibly excited and enthusiastic about that. We know condom use, chemoprophylaxis, routine screening for HIV, and treatment, or treatment as prevention, are proven strategies. They work. But we can't forget that we need interventions that can promote behavior change and impact, particularly young people when it comes to things like motivation and support, self-efficacy, coping strategies. And one of the things I didn't have the time to bring it up, but we also have another paper that we've submitted that focuses more on emotion regulation as a critical process, particularly in understanding adherence for HIV-infected MSM. Lastly, I just will conclude, I have been a proponent of the idea of integrated HIV treatment with substance use and mental health care since I started working with Kathy Sikkema at Yale, actually. Well, really before then, because I worked with her before then, but really when I started my postdoc. And she and colleagues put together this positive prevention model, really showing the need for mental health treatment when we think about HIV. But I think of this as mental health, substance use go hand in hand with adherence and sexual risk reduction. And we really need to integrate these programs and services into the care setting. We can't think that they can work in isolation. And so, I focused a lot on more of the behavioral aspects. This is not to say that we don't need structural interventions. We clearly do when you look at how education, incarcerations, how those play out when in affecting viral suppression. So when we talk about behavioral interventions, they have to occur in tandem with community and structural level interventions. Tailoring interventions at multiple levels, and focusing on precursors to risk reduction, not just assuming that because we have the pill, everyone will take it, but that some people need extra motivation, some people need extra time, and in the interim between now and that time, how do we ensure that they stay healthy, do not infect partners, and essentially, stay healthy. So that is it. I mean, I think I ended with just some pictures to promote, I think, a sense of happiness that there is a lot that goes on in our world that is negative, but that the responses tend to be incredibly positive. And I think the same for HIV. Clearly, this is an epidemic that's had a tremendous impact on so many communities, but the responses have been incredibly robust, and I just think that we have to keep those responses up, but enhance them, and not be too narrowly focused on just the biomedical, but really keep our focus also on the behavioral, social, and structural. So thank you. My apologies again for being late, and I'm happy to take any questions.